Hello, everyone. I am Dr. Alto, and I am the Integrated Care Training Director here at Neon. A lot of you have gotten emails from me, but haven't yet seen my face. So hello, I'm a psychologist that works in the Behavioral Health Department, and my role as Training Director is to provide training opportunities for staff about a variety of relevant issues, especially things that connect behavioral health to physical health and medical care, and also to provide training and supervision to trainees that come from a bunch of different disciplines, including Morgan Wiggins, who is with us today to help me co-facilitate this training. She is a doctoral NP student from CASE, and she is doing her final dissertation project on Sbirt, which is why she's the perfect person to be helping me with this today. So as you all know, we are rolling out a new Sbirt policy and procedure here at Neon, and we want to make sure everybody's up to date with it, which is why we're having this training, and there'll be follow-up as well to support you so everybody knows what they need to know. And with that, we will get started with Morgan telling us a little bit more about Sbirt.
So, hello everyone. So what is Sbirt? And I know that everyone here will have heard of it, but what do the individual pieces parts mean? So Sbirt stands for Screening, Brief Intervention, and Referral to Treatment. Now this concept can be applied to alcohol, drugs, tobacco, but in this instance, for this presentation and for the policy at Neon, we are only referring to alcohol use. So why are we concerned with alcohol use? So I like to call alcohol misuse our original pandemic, because the World Health Organization actually identified alcohol misuse as a pandemic in the late 1970s. We know that alcohol is responsible for over 3 million deaths in 2012, but World Health Organization tabulates these numbers and updates them at certain points. It's the leading cause of mortality and disability in 15 to 49-year-olds. And alcohol misuse is linked to all sorts of mental health issues, as well as plenty of common physical health issues such as injuries, high blood pressure, obesity, heart problems, liver problems, strokes, breast cancer, bleeding issues, all of which I'm sure are applicable to a vast majority of the patients that are seen here at Neon. A lot of people think of cirrhosis, which is one of the more obvious issues with alcohol misuse, but there are a lot of more subtle issues as well, such as falls and a lot of other social determinant type factors. It's also worth noting that the alcohol misuse pandemic that World Health Organization has identified for so long is somewhat overrepresented in the relatively wealthy nations, or the first world nations, if you like, such as the US. So as a response to this global health, public health problem, the public health approach was developed, and the public health approach is called Sbirt. It goes by the acronym of Sbirt, for Screening, Brief Intervention, and Referral to Treatment. Sbirt is really designed for use in primary care and specialty care, acute care settings, such as emergency room and certain trauma departments and so forth. It's really ideally suited for primary care visits in particular, because primary care is the place where so many different screeners and screening tools are being utilized. And Sbirt is a manualized approach. It's based on a therapeutic communication style called motivational interviewing. And really the point of this slide is just to show the large support for the Sbirt approach.
Thank you, Morgan. So why do all of these groups endorse Sbirt? That's because there's hundreds and thousands of studies that show that the screening and brief intervention and referral to treatment for alcohol use results in less emergency room visits, fatal injuries or non-fatal injuries, hospitalizations, arrests, motor vehicle crashes. A lot of the negative outcomes we see here at our NEON patients and that we want to address in this population can be addressed by using Sbirt. And the great thing about it is that it is designed to be brief and to fit into the care that we provide here. So if we care about these outcomes, this is what we should be doing. This is the standard of care that we should be providing for our patients. So this is a visual representation of Sbirt. So the idea is that we do Sbirt with all patients, and that's because everybody gets a screening. So if you look at all the black figures in this, it represents all the patients that come in, everybody gets a screening. However, for negative screens, nothing more needs to happen. So although it seems like you're taking on a lot, for most people, you do the screen, nothing else happens, similar to how we do the PHQ-2. But for some people who screen positive, this represents by the gray figures in the picture, they require a brief intervention. It is a red flag for us to talk about their alcohol use, and we'll talk more about how you can do that. And then only occasionally do you have someone who requires a higher level of care or a referral that NEON can't provide those services, or you need additional support for those services, and that's represented by the red. So the idea is that although Sbirt applies to everyone because it's a population health approach, for most people, you're only going to be doing the screening.
Okay, so let's look at the individual pieces parts of Sbirt. So if we start with S, that stands for screening. And the point of this slide is really to point out that our patients, by and large, our patients are not going to volunteer this information. We have to ask them. The reason that we're asking them, in order to put this into context, both for this presentation, but also when presenting this idea with patients, the reason that we're asking is because this is very relevant for health, physical health, mental health, health. And this is a healthcare organization. So whether or not that link is clear to the patient, typically I find that it's not. I happen to be a nurse practitioner in psychiatry at a local FQHC, and generally I find that this link is not obvious, I guess, to the patient. So we need to make it obvious. Well, you've come in today to get your high blood pressure medicine. Did you know that alcohol is relevant to high blood pressure? And even that might be actually sort of eye-opening for a lot of patients. So the way that we are going to screen at NEON is called the AUDIT-C. So this is the screening tool that's been selected. This will take the place of the previous screening tools you might have heard of, like the CAGE and the DAS. The idea is that the AUDIT-C will be done every visit, similar to how the PHQ screen is currently done for the visits here, so that the screening is universal. So the AUDIT-C is already in NextGen for you. Now I have some details here about the psychometric properties if you're interested. I can tell you the audit, the original alcohol use disorder tool, was developed by World Health Organization in about the early 80s, and it's, so it's been around for a long time, and it's quite, it's had the advantage of more psychometric testing opportunities, I guess I would put it that way, as compared to a lot of the other alcohol screenings. It is 11 questions, but like I said, it's very good. It's sort of the gold standard. The AUDIT-C came out a bit later, and it has extra advantages in that it's short. It's 3 questions, so that tends to go over better in a busy appointment. Now, the AUDIT-C has been psychometrically compared and compared favorably to the full audit, and therefore it was selected for this purpose. Let's talk about how to interpret an AUDIT-C. Okay, so the way that this works, a couple things to point out. Males and females, from a biologic standpoint, have a there are differences when you're determining the risks from alcohol consumption. And this has to do with percentage of body fat to body water ratio and stuff like that. So basically, females, biologic females, are at higher risk for the physical consequences of alcohol consumption. In other words, even at lower amounts, their health risks are greater. Okay, and that's not just with the audit or anything like that. That's just like a biologic reality. So you'll see that with all of these screeners, generally, and including the audit, the cutoff is different for men versus women. And that is why. So the way that the AUDIT-C is scored, it goes from 0 to 12. 0 would be like I abstain from all alcohol, for example. That would be a 0 maybe. And 12 is a very high risk. That's a risky use right there. Part of what I'm saying goes along with the latest and greatest from the field of addiction medicine, which does tell us that addiction of any sort really exists along a continuum, much like most chronic diseases. If I'm thinking about diabetes, I'm thinking of the continuum from pre-diabetic to oral agents to insulin, for example. If I'm thinking about alcohol use disorder, I'm thinking along similar lines: no use, some use, risky use, severe disorder. So the AUDIT-C is trying to capture what risk exists, if any, and then if there is risk, how severe are we talking? And that's the point of the number. So 0 would be like no risk, and 12 would be very, very high risk. And you'll see here with men, if you have a AUDIT-C score of 4 or higher, you're at a positive screen. In other words, ding, 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 red flag, risky, all the way up to severe alcohol use disorder. And the same is true for women, except that number is only 3 all the way up to 12.
Thank you, Morgan. So this is a little cartoon about the way a traditional medical visit often goes. To poke fun at ourselves a little bit, we know that we give a lot of advice to patients. We have a lot of recommendations, a lot of things to tell them about how to live their lives. And sometimes it feels like they're not listening, and sometimes that's because they are not listening. So the idea is that, can we have a different approach? Can we talk about alcohol use in a way that has people think about it a little differently and be more engaged and involved in the process? And so that's what we're going to teach you how to do today, is how to do, after the screen, that brief intervention, referral, and treatment part. How do you do that brief intervention to address alcohol use without just telling them to stop drinking? So we have structured this into what we call the 5 A's. So after you do the screening for any positive result on the AUDIT-C, you're going to walk through the 5 A's. And we're going to go through this step by step, but they're ask, advise, assess, assist, and arrange. And we'll also be giving you a handout that has this as a script to help you remember all the things you need to do when you have a positive screen on the AUDIT-C. And it's not just what you say, it's how you say it. So what I mean by that is that patients often can feel defensive, ashamed, overwhelmed, or confused about their alcohol use. And because it is so stigmatized in our culture to struggle with drugs and alcohol, there's a lot of fear of judgment. So we have to go above and beyond to show that we're empathic and patient-centered and non-judgmental and supportive. We want the patient to feel like we are working with them on the same team to help them meet their goals, not like it's us versus them. And one easy trick to create this kind of safer environment is to make sure you leave some room for silence. So asking open-ended questions and giving patients a chance to respond, that can help them feel more safe and less like you're just going to tell them what to do and they might feel judged or shamed by that. So the first A that we start with is ask. So this is after the screener. We are going to look in NextGen and see what the results of the screener are as a provider. And you're going to review those, but we're also going to get more information. because you often get more information when you ask an open-ended question. So start with an open-ended question. Is it okay if we talk about your drinking? Tell me more about it. I talk to all my patients about alcohol because it has health consequences is a really non-judgmental way to start that conversation. So we have a couple of other tips and tricks for how to get them to talk more about their alcohol use, but the idea is to get more information, start that conversation, get it going, and get an idea of what they care about. How do they feel about their drinking? Get them started so that you can jump off of what they give you. So they might tell you right away, I hate it and I want to change. Great, let's go from there.
So the second A portion of the brief intervention is the advise portion. And advise is very straightforward because you've already asked and kind of verified what was filled out on the AUDIT-C, and you've sort of just double checked quickly that you have whatever score is correctly reflecting their alcohol use. Then if you have a positive AUDIT-C score, that means that you have someone who is drinking above these low-risk drinking limits. So that's a teachable moment. That's a point where you say, oh, well, I see your score is this, and did you know that the NIH has low-risk drinking limits? And if you are above these limits, there are increased risks of heart disease, liver disease, certain cancers, stomach problems, mental health issues, et cetera, et cetera, et cetera. You can fill in the relevant from their health history. So the low-risk drinking limits are from the NIH has a branch called NIAAA, which stands for National Institute on Alcohol Abuse and Alcoholism. And they say, again, it's different for men versus women. They have established these risks that for men, well, what you would say is, oh, okay, did you know that the NIH considers drinking more than 14 drinks per week for men, or if you're talking to a woman, more than 7 drinks per week for a woman increases your risk of ... And, you know, it's not you saying you're drinking too much. It's, well, there are these guidelines out there. I'm not sure if you're aware of them. Let me advise you about them. It is very important to standardize what we're talking about so that we're all using the same language to describe equivalent things. So all of the drinks on this slide are equivalent in terms of their amount of alcohol. If you didn't get sort of specific with this, you might miscategorize someone who, for example, some people don't consider beer alcohol. I actually run into that quite a lot in my practice. So I have to specifically ask in those instances, are you drinking any alcohol? Okay, the answer may be no. All right, are you drinking any beer? Well, that answer may be different. So it's really important to get the specific information so that you're not accidentally miscategorizing someone and telling them all sorts of information that may or may not apply based on the actual answers.
And one thing that Morgan and I discussed is that for some patients, when they say 1 drink, they might mean a pint, which is the equivalent of 9 standard drinks, which is 1 drink doesn't sound risky and isn't risky based on the guidelines, but 9 standard drinks definitely is. So it gets at that idea of getting the accurate information by asking important follow-up questions. So the next A that we have is assess. And so this is not about assessing their drinking. We've already done that. This is about assessing their readiness to change. So readiness to change is this concept that applies to universally human behavior, where we all have things that we know we need to change or know we should change. And some things we are very ready to change and prepared to make a plan tomorrow. And some things we're not ready to even talk about it and don't even want to consider anything related to talking about that change or hearing about it or thinking about it at all. And we've all experienced this. Let's say that there's been a time in our life when we know that we need to exercise more in order to improve our mood and our health. Maybe someone tells us that, and if you're not ready at all, you're like, I'm fine, I don't need to exercise, I think I'm pretty good, right? You're just in denial, don't want to think about it, don't want to have any more conversation. Whereas there's been other times when you are so ready to make that change and people are talking to you about it and you're like, yeah, I bought a bike and I'm going to go biking tomorrow and I have a plan for how I'm going to do it. And a lot of people are in between and in the middle. And this is all normal. It is normal to feel confused and ambivalent about making changes in your life, especially when it comes to your health. And we're all like that. So remembering that people are in different places can help us be more empathic. And we can remember a time when we didn't want to make a change either, but it's still our role to talk to patients about it. But it helps us to understand where they are. And so this readiness ruler that we have a picture of on this page, Morgan is going to tell us about how we can use that to help understand where patients are.
So I like to use the readiness ruler a lot, and it can make abstract concepts like changing and alcohol and health risks down the line, etc. It can make them very concrete and right now, which I appreciate. So it's very easy. How you use the readiness ruler is that you say, okay, on a scale of 1 to 10, where 1 is I'm not ready, don't want to talk about it, and 10 is I really want to change, I want to change today. How would you rate your readiness to reduce your drinking today? And if the patient says, I don't know, like maybe a 4, your job is to say, great, why not a 1? And all the reasons that they actually think that they could do it and the reasons, their motivations for maybe wanting to change, that's called positive change talk. And you've gotten them to talk about it. And that's a powerful thing. That's much more, I mean, we all know that's much more powerful than me saying, you know, you're drinking a lot, you know, that's kind of bad for you. What you do not want to say, this is really the only thing about the readiness ruler. The only thing that you don't say is, why'd you say 4? Why not 10? Because then you're doing the opposite and you're having them tell you a bunch of reasons why it's hard to change, but we already know it's hard to change. We don't need to like harp on that point. What we want to do is elicit the positive change talk that's so much more powerful than any meeting with me or you or any provider will ever be, right?
And this gets at the idea that we want the change and the urge for change and the desire to change to come from the patient. And whenever we can make that happen, the readiness ruler helps us do that.
Patient-centered. The assist portion, so the assist A of the brief intervention, because remember we're talking about the BI portion, this is really sort of a recap. You're sort of closing out here. So this is a recap with an offer to assist. So, all right, let me summarize. You are drinking XYZ amount, which puts you in a high-risk drinking category. Your drinking is impacting your insert chief complaint here, your hypertension, for example. You indicated that your readiness to change your drinking behavior is a 4 out of 10 today. You want to quit drinking because of insert the positive change talk that they said. How can I help? I would like to help support you in your goal of cutting down drinking. How can I help? Then you have to stop talking and allow them some time and some space to produce an answer. You don't have to wait like forever or anything. I mean, but you do have to wait. You have to pause. If there has been a little bit of time and there doesn't seem to be an answer forthcoming or nothing concrete, or maybe they say, I don't know, it's okay to suggest, well, some of my patients, you know, I mentioned I'm a nurse practitioner, so some of my patients want me to prescribe a medicine to help. And there are some options like that. Or no, if that's not a route you want to take, some of my patients find it helpful to decrease the amount of beers that they drink per night. So for example, from 4 beers per night to 3 beers per night, and that can help them toward their goal of decreasing. Then we talk about it in a couple of weeks again, and we can see how that went for you, for example.
So what I love about the example that Morgan gave there is that instead of telling the patient what to do, she gives some options, which is much more empowering. So some patients like to do this, some patients like to do that. What do you think might work for you? And having patients who choose to make changes is going to be way more effective than us just telling them what to do. So the last A that we have here in our 5 A's is arrange. For this step, we really want to make sure we thank the patient for talking to us about this issue and provide them with, again, options for how we can arrange follow-up support. So that could be following up an appointment with you to see how they're doing on their goals. It could involve referring to behavioral health, especially for cases you're really concerned about their alcohol use. You can highly recommend that they follow up with behavioral health and explain that we're a team of experts in substance use and helping people improve the quality of their life, and talk a little bit about what that referral would look like and place it for them. You can also have as an option that you offer to patients community and online support groups like 12-step programs like AA and Smart Recovery. And I'm going to give you a handout that you can always have on hand that has those numbers on it so you can remember to give that to patients. But again, the idea is that let's provide patients with options for how we can help them meet whatever these goals are, and then arrange for those options to happen, whether that's placing the referral or giving them information about groups.
Some of the common pitfalls that we've really been talking about the entire presentation, I would say. You don't want to, yell at people. You don't want to really instruct people at all. You need to quit drinking or something like that. Is just not, if it were effective, that would be a different story, but it's not. You don't want to sort of doomsay, or it sort of comes across like you're making threats. You're going to die if you don't quit drinking today, type of thing. You don't want to avoid. Minimizing kind of goes along with avoiding, because it's difficult to talk about this. Well, sorry, we're out of time, so I can only talk about your blood pressure. Well, they're related. And you don't want to sort of dump this problem onto someone else. Well, that sounds very hard, but you have to talk to someone else about that. I mean, and again, that's really not the culture at Neon, I don't think so. But it's worth mentioning some of the common things that you want to avoid. Now, so just to kind of reiterate, the 5 A's that we've been talking about are the brief intervention. Okay, so the brief intervention is composed of those 5 A's that we've been talking about for most of this time. And it might seem like, man, I don't have time to even do one more thing, but actually it's been studied. How long is this little brief intervention supposed to be? More is not better. 20 minutes is not better. So 5 minutes of advice, in other words, 5 minutes of brief intervention, has been shown to be as effective as 20 minutes. Okay, that's good, because 20 minutes I don't have, but 5.
And we know that, it's easy to say, it's easy for us to tell patients to stop drinking. It's easy for Morgan and I to say, just start doing Sbirt. But when it comes down to it, there are barriers that get in the way. And obviously the biggest one that comes up for people is time. There's so many things to address in a primary care appointment or other types of appointment, and our patients can be really complex. It is hard to know how to fit in alcohol use. But we actually hope that by using this process of we're always screening for it, that will help you address it more efficiently because you already have some information from the screener. And we want to make sure that it doesn't fall through the cracks. As we've mentioned again and again, it's so relevant to so many issues. We don't want time to be a barrier because it's probably related to some of the other things you've been talking about during that appointment. I think a lot of us are also afraid of having patients be angry with us for asking them about their alcohol use, and I've definitely had that happen to me. However, it's our job to go there with patients. And sometimes even when patients are angry, we are planting seeds about this process that months, years down the line, they might remember and think, you know what, it's time for me to get serious about quitting drinking. They might remember what you talked to them about, even if they were really angry with you in the moment. And it can be awkward to talk about things like this, especially with patients who are reluctant to talk about it. But as providers, I think that we're really good about diving into those awkward topics. And there's a lot of awkward things that we do with patients. And this can just be one more thing we add to the list. So we understand that there are barriers to doing this, but we also think that with practice, it will get easier for everyone to talk about alcohol with patients in this way. It becomes second nature and you won't even need the script in the future. So, you know, we talked about the 5 A's, and part of that obviously is documentation and workflow and setting the referrals up in next gen. And so we're not going to cover all that today, but we are scheduling follow-up meetings at all the sites to make sure that Morgan and I are there to support you to make sure that all of this makes sense, so that we can help you when you do the documentation correctly, help you do the right coding and billing for Sbirt and for the AUDIT-C, and make sure that your workflow makes sense. So, because we don't want to be giving people additional work if it doesn't help patients. So we want to make sure that you are able to help patients by using this new policy and procedure. And we are available for feedback. So please let us know what's working and what's not working, and stay tuned.
Thanks for your attention.
Yeah, thank you everybody for your time. We really appreciate it. And our last slide just shows how well researched this presentation is and supported by the evidence. And we will be seeing you all soon.